Greetings, everybody. Uh, this talk is about the radiation safety in radioembolization with yttrium-90 for hepatic carcinoma and use of yttrium-90 PET CT imaging, which will be in the second part. Yttrium-90 poses a radioactive contamination hazard in the IR suite. Guidelines on handling radioactive liquid spill in an IR suite will be covered in this talk. This is a typical scenario in an interventional suite with the radiographer separated by the lead glass. As you can see, this is the nuclear medicine surgeon who is going to do the infusion with the yttrium-90 in the perspex box, and the patient, of course, lying over there. And as you can see, this must be the IR radiologist already with his arms red, and that might be a nurse there with a lead apron, another nurse here, and another radiographer here standing here. So this is a typical scene in essence, you never know where the yttrium-90 spill may occur, and that's what we will be covering in today's talk. Liquid spill, in essence, when it happens, don't panic. You need to stay calm and execute the plan accordingly. The management of radioactive spill in an IR suite, immediate steps are in the room, transferring the patient out of the procedure room once the procedure is complete, and the cleanup necessary post-procedure. So remember, the patient comes first. The patient's health is important. Patient needs to be stabilized, irrespective of whether a liquid spill had occurred. And if there is a possibility of continuing the procedure, got to complete it. Otherwise, need to reschedule this patient. So this patient is stabilized and removed out of the room, then we can do the cleanup. Immediate steps. We need the commander has to be established, and generally it would be the nuclear medicine physician or the technologist who would be the person to take over the control, because he or she will be familiar with the decontamination of a radioactive spill. And next, what do you do? Call the physicist. Okay, and for any assistance and further knowledge on radiation safety and decontamination, restrict the entry and exit out of the room. Gown, basically you need a wipe down, replace the full PPE because the original PPE could be contaminated, so replace all the PPE, complete the procedure as I mentioned. Patient comes first. Procedure is completed, whichever part of whichever process of it, the way it got stopped when the liquid spill occurred, and once again keep calm and carry on. Right? Transferring the patient, we need to have a separate team for that, who needs to be outside the IR room all ready to receive this patient, because the team inside the IR room, which has got a contamination, cannot leave this room, because unless they changed out of the PPE, because otherwise the rest of the department will become contaminated as well. Survey the bed at the door location, and then we need to send the patient to a holding area while the patient is stabilized, BP and vitals checked, before the patient is sent back into the inpatient ward, or for that matter sent off as an outpatient. The intra-procedural skin contaminations, if that does occur, we need to call in the substitutes. And we need to degown. That means the person who is contaminated has to degown and head to the nearest shower and do a resurvey of the radiation contamination at the IR. So the staff, by this time, the physicist would have would have come in, and there may be other additional staff may be required to do the survey of staff who had been contaminated, who went for a shower. And if necessary, this staff needs to go for a re-shower as well. Post-procedure, clear the staff to leave. Before they are leaving the room, we need to survey each and every one of them, include especially their foot for any contamination, decontaminate the room in essence, and of course look after the waste of radioactive waste, which will be a big volume, and then of course restrict the room until the physicist has declared that the room is clean and clear of radioactivity. Aftermath, well, there should be a checklist to follow and what are the things to do, this is something that we can do it during peacetime and prepare for the worst, so that this checklist can be followed A to Z. Then once the physicist has given the declaration, we can reopen the room for other patients or other procedures. The root cause analysis has to be performed, perhaps a simple asking 5 whys, WHY, why did it occur, what was the reason, etc. So that will actually help to determine what was the cause of this particular incident. And the spill management training, I cannot stress enough, has to be done annually, and everybody has to be tested for this as well. So in a nutshell, we need to have competency assessment for the nuclear medicine staff who are the commanders in this sort of spill in the interventional radiology suite. Whereas the IR suite, whether they should know how to do this, well, they need to know the checklist and how to do these things, but I do not think they need to have a training on an annual basis, especially not something that we need to have a competency assessment. But it would be good to refresh their mind on the theory aspect of the decontamination process. A decontamination kit has to be kept within the IR suite. In fact, every IR suite should be equipped with this, and it's not something very difficult to obtain. It's something that you can get from your material management department, or if not available, at least from the regular supermarkets or pharmacy. Okay, these are the waste bags as what you would use in your country. Liquid soap. This is nothing fantastic because you do not need to use decontamination soap, but a good soap, liquid soap solution that you can get from a regular supermarket would suffice. Absorbent paper, which is available in the hospital, gauze, swabs, scrubs, etc., just to absorb the radioactivity, and the usual gloves, etc. Now, decontamination basically would help to remove the removable contamination, and there will be some stubborn non-removable contamination which are considered as fixed contamination, and for that we need to wrap the place up or the location up to contain this non-removable contamination or the fixed contamination. And of course we need to look at the waste disposal of it, transfer all of them into the waste disposal store, perhaps in the nuclear medicine department, and then do the survey again. Emergency action card has to be created. This is something like on a A4 sheet, where it depicts the immediate steps necessary, and then because in a panic situation, it's best to follow something like this, simple like this, because it'll be nice for an SOP, but SOPs are long and large and may not be accessible, whereas these action cards could be kept with the decontamination kit and could have easy access. So they are not going to be telling you all the work instructions, etc., but rather there would be simple steps, a point form to kindle or to remind the staff what are they supposed to do, and they are in chronological order, so one needs to follow this particular order to basically mitigate the situation. I'll be happy to share this Word document if necessary. General sequence of management in an IR patient is contaminated with yttrium-90. Well, the yttrium-90 spills occurs once in a while. A quick cleanup of the patient by the physician would be sufficient, especially if the skin of the patient has got some contamination. All staff change their sterile gowns, PPE, etc., including the cap and mask, and recommence and complete the patient's procedure, as I mentioned earlier. Transfer the patient out of the interventional radiology suite, management of staff contamination, decontamination of the facility, and declare the IR room safe for other use. So a little bit more detail of this yttrium-90 spears. Basically, it's used for HCC, a hepatic carcinoma. The penetration is about 1.1 centimeters with a mu of 2.5. Half-life is about 64 hours, which 94% of the radiation is delivered within 11 days within the patient. Beta particle hazard would be the radioactivity going onto the grooves of a television monitor like this in the IR suite, for example, which you couldn't access or clean further, direct skin contact or contamination of the skin, and of course the worst case scenario when there is some ingestion and a skin absorption of the yttrium-90 beta particles on the staff. Now, the two types of contamination, all of us know that one is removable and the other is fixed. Removable is much easier to handle because as you do a proper, thorough, multiple iterations of cleaning, you would be able to remove the contamination, whereas fixed contamination has a problem because it has gone onto the grooves, for example, and you just can't do any more cleanup. So what you need to do is use a polythene see-through sheets and cover the contamination and wait for the half-life to kick in and also decay the radioactivity out. But one good thing about fixed contamination is it will not cause a contamination, okay, a further contamination of staff or patient, because it has gone onto areas or grooves which just makes it impossible to clean or, for that matter, contaminate something else. So how common are spills? Well, we looked at the literature, and there was one back in 2015 which looked at 900 deliveries. There were 11 occlusions, or 1.2% of the time, and there were 5 cases of leakage and 1 spill. Only 1 patient required a second procedure of yttrium-90 infusion, and all resin deliveries were effective or successful. This is a schematic that was published in the paper, and these are the numbers, and against the numbers, the dates when it occurred. So there were 2 of them that occurred close to the patient. At the lower lock, perhaps it's not well connected, there were 2 times, and most of them happened within the plastic shield around the V-vial. Okay, as you can see the numbers over here. This is the data that you can also look at the reference. And this is a clumping that is sometimes seen because if the yttrium-90 is left to stand for a while, they will start to they're a bit sticky. They will combine with themselves. At my hospital, yttrium-90 spills did occur, and but it was not that frequent. Most of the time, it would be a clumping within the V-vial or around the V-vial, as was published. Data shows there was 1 spill where, as I mentioned a little bit earlier, which occurred, which contaminated the interventional radiology staff. Because there was a splash of radioactivity because of the pressure was not right, and of course that is the reason why I'm talking about this, because post-incident we had a root cause analysis. We found out the cause of the problem, as well as came out with mitigation as to how to contain such a situation if it does occur again. So we had a lot of teaching being done for the NM staff, the commander, the fact that the staff cannot leave the room. All these things were very important, and we also came up with the SOP to look at this aspect of it, of the mitigation steps of how to look after if there is a spill. In summary, the yttrium-90 spillage management, patient, staff, and environment are safe. We looked after radiation biology. That means there is no contamination, and there needs to be decon kit and emergency cards for quick referral for the staff. We need to do a debrief, cost analysis, and also staff training if there is something that we can learn. In summary, I would like to say that yttrium-90 resin microsphere cert is safe from a radiation safety perspective. The radiation exposure of staff are low and well within their annual whole body and extremity dose limits. The contamination risk is low during the procedure. However, we need to undertake a risk assessment to determine where, when, and how a contamination can occur. Mitigation, control, and management of a contamination needs to be planned. Decon kit needs to be easy to access. This is something that we learned from our lessons because this was not available when the spill occurred. So we had to quickly go